Thanks, Sergey, for having me here. Very nice to be here, meeting and seeing some of old friends and meet new ones. As as you mentioned, I'm going to talk about our initial experience using Circer in my lab. So basically, I have three studies to share with you. We started using Circer almost a year now. And the intention was really to evaluate the metabolic markers that you provide in assessment of patients with acute stroke. So this is the first study. So as you know, infarction growth after successful recanalization is not uncommon. Has been reported in 20 to 50% of patients. They can have infarction growth despite having successful reperfusion treatment. So we basically aim to investigate the association between metabolic markers, specifically OAF, within the penumbral tissue and its relation with infarction growth. So this was a retrospective study. We included patients with anterior circulation large vessel occlusion who had successful reperfusion. They must have pre-treatment MRI, including MR perfusion, and a follow-up MRI within 48 hours to evaluate the infarction growth. This is just the pipeline that we used. So we use ADC 620 or less to basically segment the ischemic core. We use Tmax of 6 seconds to segment the critical hypoperfused area, and then we subtracted these to basically get the penumbra. And then we did image core registration with the baseline OEF maps, and then we extracted voxels to basically evaluate the relationship with with infarction growth for a statistical analysis. We also obtained a contralateral OEF for normalization purposes. So this is the results, a little busy table, but we basically, at this point, we have 89 patients included in this study. You can see that about 1/3 of these patients, they actually have infarction growth. Infarction growth was defined in this study as growth of 10 ml or more, basically. About 1/3 of patients, they did show significant infarction growth. These are some of the basic demographic and clinical information that we have. This is the univariate analysis we included here, and as you can see, the OEF values were significantly lower in patients that have infarction growth, both in the core and in the penumbra. We also the initial core volume was also significant in the univariate analysis. So patients who had larger or more infarction growth, they have larger infarction to begin with. Interestingly, the size of penumbra was not significantly different between the patients with growth or without growth. And also we looked at the collaterals by just using what we have available to us. That was the hypoperfusion intensity ratio. And this was also not significantly different between two groups. So in the logistic regression analysis, when we include all the variables, OEF in the penumbra was really the only independent variable that stayed significant independently to predict basically infarction growth. This is just the voxel level data between patients with no growth or small growth and patients that they have 10 ml or more growth. And you can see that these are voxel level data. See that there's some overlap. These are the median values. And this is the AUC analysis for voxel level data that, as I mentioned, it remained basically independently significant and predictive of infarction growth. This is just one example. We presented this just a few months ago in the International Stroke Conference in Los Angeles. Just an example of two patients here. One with infarction growth one with no infarction growth, and you can see just visually looking at the OAF within the penumbra. These are Tmax of 6 seconds. So basically highlighting here for you the critical hypoperfusion. You can see just visually looking at this OAF is high here. And this is the patient who didn't have any growth. And you can see that the OAF is not so high. It's also a little heterogeneous in the Tmax. And this is the patient who had infarction growth in some of the penumbral region. They both received a successful reperfusion. So in conclusion, we think that penumbral these are relative OAF values, so they're all normalized to contralateral side, and we think that penumbral OAF values is promising in prediction of infarction growth. And what we showed in this study is that if the relative OAF was more than 1.8, that's the ratio, that was protective. And when it wasn't, these are the patients who sustained further ischemic injury and infarction growth. And again, this is just another example that we included in our presentation at ISC. So moving to the second study, evaluating of the role of OAF in diffusion reversal, the so-called GHOST score. I think Alexander talked about this in the morning, so I'm not going to spend a lot of time here. Basically, this is a very similar concept. We basically decided to look at the metabolic imaging and whether they can actually be used to further refine ischemic core estimation and predict reversal after a thrombectomy. So again, this was a retrospective study. We evaluated patients with anterior circulation, large vessel occlusion. For this study, we included 2C or better, so 2C or 3 reperfusion only patients. They must have pre-treatment perfusion and post-treatment MRI within 48 hours. This is our pipeline. So basically, again, ADC 620 for ischemic core definition. Follow-up MRI, we use diffusion weighted imaging to evaluate the final core. This was within 24 to 48 hours. We did co-registration between these two, and then we subtract so the final infarct and the ischemic core, initial ischemic core, and then we have 3 outcomes. We had some boxes that they showed reversal, so they were basically not infarcted in the final infarction. Some that they persistently remain infarcted, and some voxels that they have new infarction. I don't have the result for the new infarct voxels. We see some really interesting signature in their values, but I don't have a systematic voxel level data to share with you at this point. But again, we co-registered these 3 masks with the OAF, and we extracted the voxels, and again, we use the contralateral side to normalize the values. So we look at also CBV, CBF at the same time, since we have the data, and again at the voxel level data, even though differences are not significant at the median level, but there was significantly higher CBV in the cervi voxels, significantly higher CBF in the cervi voxels, and these are the OAF values again. This significantly higher in the cervi voxels compared to the voxels that they remain infarcted, and the CMR2 was also significantly lower in patients that they remain in voxels that they remain infarcted. But when we put everything here, again, this is just in the multivariate analysis, and you can see all these p-values are significant. But if you look at the combined model that you could generate from these 4, you can see that the relative OEF AUC is 0.7, and the final model, including all 4 variables, would be 0.72. So the main driver of this statistical significance is OEF, and as you can see, this is OEF basically here. That's the final model, and the rest of them are here. So that's CBV, CBF, and CMR2. So if you interpret this data, we think the OEF is really what's driving this reversal of diffusion, or basically what is the main determinant of persistent infarction versus cervi voxels, basically. This is just one example. We are going to present this in a couple of months in ASNR in Philadelphia. For those of you who are attending, I'm looking forward to see you there. Just one patient here, 2 slices I'm showing you here. This is just a baseline imaging before reperfusion. That's after reperfusion. In 24 hours, you can see that this patient has some persistent infarction, but some also reversal of the voxels. And again, if you look at the OEF, this was significantly higher or high in the penumbra and in the region of reduced diffusion, which eventually they reversed. So this is the last one. And next few minutes, I'll talk about. This is a study that we've done, and we basically doing the phase 3 trial. This is related to a neuroprotection basically trial that we use. And as you know, the neuroprotective trials are coming back. There's a lot of medications are coming back. Some of these device developments are happening right now, and there's some excitement, I think, in the stroke community about neuroprotection in the era of thrombectomy. So this was basically a helmet, as you can see, that is designed to provide direct electrical stimulation to the brain. And it basically the goal is really to increase collateral. So by doing that, you basically have two. These are the two ways that this would provide neuroprotective properties. One is by inhibiting the peri-infarct excitotoxic effects, and the other one is by enhancing collateral perfusion due to its vasodilatory properties. So this was when it was done initially. This was the phase 2 trial. This was a randomized sham-controlled dose escalation clinical trial. We included 10 patients, 7 active, 3 sham, and we basically image these. These are the key inclusion criteria for these patients. These are stroke patients who presented within 24 hours from the onset. They must have ischemic core and penumbra based on imaging to get enrolled, and they should at this point they should have been ineligible for reperfusion therapies, because we didn't want to confound the effect of neuroprotection with treatment for this phase 2 trial. And then we imaged them at baseline. We imaged them again at 2 to 4 hours after stimulation, and then one more imaging at 24 to 36 hours. And these are all done with perfusion included. What we measured was basically we look at the core, ischemic core, final infarction volume. We look at the penumbra sequential change in penumbral volume, and we also look at the CBV values and RCBV specifically along the stimulated area. What we found was that in active patients in comparison to patients that they didn't get stimulated, we have a 100% reduction in the size of hypoperfusion. We have almost 66% penumbral salvage, and we have significant increase, 64% increase in their RCBV values following stimulation. So this is just one example here. This is the patient who presented with MCA infarction. He had like an M2 occlusion there on time-of-flight imaging. That's Tmax. This is the CBV map here. This is just the helmet that would show you the region of stimulation. So this is where you stimulate by applying this, so these are shown in axial, coronal, and sagittal format. And then after stimulation, you can see that CBV is significantly increased. This was before, this is after, and this is 24 hours. So this is the 2 to 4 hours imaging. This is the 24 hours imaging. You see that CBV is significantly increased. You can see that the Tmax is smaller in size and also less in intensity. So more red here, less red here. And even on MRA, there was some trickle of flow in the M2 segment in this patient. So I put this data through Serker, and we basically look at the OEF, CMRO2, and leakage. And we find some interesting results actually here. So what I'm showing you here, again, the same patient that I showed you before. This is baseline, 2 to 4 hours, 24 hours. These are Tmax values. You can see that there is incremental change in size of Tmax or penumbra after stimulation. incremental increase in CBV values. And if you look at the OEF, you can see that the OEF is dropping. So it was higher, it was lower, and even lower. CMR2, there's some increase in CMR2 compared to the baseline. And then interestingly, in leakage, you can see that in the 2 to 4 hours after the stimulation, there's some increased leakage. And then it dropped compared to this point, but still higher compared to baseline imaging. So when you trace this data, this is what we see. CBV is increased, as we saw in the initial study. OEF is basically progressively decreasing, and I think that's what you expect to see, because you're basically increasing the collateral flow, so the brain doesn't need to extract as much as oxygen anymore. CMRO2 is increasing, and the leakage is basically increasing and then decreasing, but still higher than the baseline. So I think this stimulation is probably causing some blood-brain barrier, obviously disruption or impairment, and there is some leakage, which will be a concern for the next phase trial that we are going to start enrolling next month. Just another example. This is actually a nice example because this patient had bilateral PCA infarct. So we stimulated the left side and we left the right side alone. So this actually could act as its internal reference for this patient. And you can see in this patient, again, the stimulated side, the left PCA, you can see that there is decrease in Tmax. There is increase in CBV values. And you can see again the OEF is dropping, CMR2 is increasing. And leakage, is basically, leakage maps were not great, but if you draw the same ROI, there was some increase in leakage compared to the baseline. So again, when you trace the data, you can see the same trend, increase RCBV, decrease OEF, CMR2 in this case, still higher than the baseline, slightly higher, and there is definitely increase in leakage in this patient following stimulation. So in summary, again, I share with you the initial experience we have in my lab looking at metabolic imaging for patients with stroke. We think there's some excitement in terms of applying metabolic imaging and what kind of information they can provide in addition to just routine diffusion and perfusion imaging. We have shown that elevation of OEF in the penumbra could be protective, especially this relative OEF of 1.8 or more. At least in our data showed that it could basically predict stability, and if it's lower, then could be associated with infarction growth. As we've seen through several studies so far, the OEF also can predict diffusion reversal and can be used for refinement of ischemic core. And I think this is where we're really excited to see this, and basically figure out where we can plug this in terms of evaluating patients with neuroprotection trials, because I think this metabolic imaging could provide some really, really interesting physiological insight in these patients. And with that, I thank you very much for your attention. I also like to thank my team here. There's a bunch of labs that we are working together at UCSF. All the focus is really on cerebrovascular imaging. Mona is really everything I show you, all the maps and all the graphs and the statistical data. She's our postdoc, and she's doing an amazing job at UCSF. Thank you.
Thanks a lot for sharing.
Thank you.
I'm so curious your thoughts there.
I think we're basically massaging the brain a little bit, and just increasing the CBV. To be honest, we actually discussed this internally, with the device that is being developed right now. But it's just probably just that the cathode ion stimulation, direct stimulation, that is causing some increase in several, like vasodilatation, basically. And I've seen, I think that has been described in animal models. You know, they used this in animal models before, many years ago, actually, almost several decades ago. And that direct electrical stimulation has some vasodilatation properties. Yeah.
I'm so happy people are talking about.
Yeah, we'll see. See. Okay, yeah, thank you. No, thank you.